Okay, well, welcome everybody to this webinar on genetic neuropathies. I'm Benoit Gentil, and I'm going to share with you my screen and start the presentation. Okay, so welcome for this seminar. I will first make a little introduction about genes and peripheral neuropathies. I'm mainly the guy who is going to talk about axonal neuropathies. Uh, there's a lot of causes of peripheral neuropathies that you will find. It's actually one of the most common neurological disorder, I believe. But you have autoimmune disease that can cause peripheral neuropathy, diabetes, infection. But you have inherited disorder caused by genetic mutation, like Charcot-Marie-Tooth disease, and other type of hereditary neuropathy. As you can see, the list of agents that can cause peripheral neuropathy is quite long, and but we won't see all of them, and we focus for this webinar on the genetic cause of peripheral neuropathies. So the first thing I wanted to share with you is what is the proportion of axonal neuropathies in general, and it's quite difficult to find some data. And you have here some data that are coming from Norway and Netherlands. And you will find this is the number of patients. This is a table showing a number of patients here in Norway, Netherlands, or USA. And idiopathic axonal neuropathy are quite prevalent in Norway and Netherlands, a little bit less in USA. And you see also here that this is a proportion of patients affected by hereditary or genetic causes of peripheral neuropathy. And you see that's still quite rare if you look at this table. So genetic causes of peripheral neuropathy are still rare. You have some specific challenge with peripheral neuropathy according to some country, like in USA. Just to let you know that diabetic neuropathy can be triggered approximately in half of the patient. You find this 46% in USA, for example. So this is a lot, but just to tell you that genetic causes of peripheral neuropathy, especially axonal neuropathy, are quite low in general. What we see here is actually the pathways that are mainly affected. We are affecting peripheral neuropathy are affecting these lower motor neurons and the motor neurons and sensory neurons that are connecting to the muscle. The causes of peripheral neuropathy is, at least from a genetic point of view, has been quite a long track. And so far, there's more than 100 genes that have been identified to cause peripheral neuropathy. So that's quite a lot. There's two types of peripheral neuropathies, demyelinating, but Dr. Massey is going to speak about this, and neuronal or axonal neuropathy. This neuropathy are called demyelinating or axonal neuropathy, depending of where they strike in this pathway here. So if they strike the neurons or the Schwann cells that are wrapping up the axon. This axonal form of peripheral neuropathy are mainly juvenile disorder, starting in the first decade. One of the characteristics, but I think Dr. Massey will have more picture to show you, is an amyotrophy in the peripheral part in the limbs, and especially in the foot. So, like I said, there's quite a lot of genes involved in causing axonal neuropathies and also causing demyelinating neuropathies, but I will focus mainly on the gene involved in axonal neuropathies here. As you can see, you have a list of this gene. It's not an exhaustive list. You can see the complexity of of this disease. And here's the different genes that are involved in peripheral neuropathy are written here, but they are grouped in category of function here. So you have genes that are affecting mitochondria, for example, like GADP1, MFN2, mitophysin, which is probably the most famous of these genes. You have other genes quite rare, like HADHB, involved in the beta oxidation. And you see now, if you go through this list in blue, you have different functions like endosomal sorting and cell signaling that is affected through the mutation in these genes. The nuclear envelope also and the RNA processing can be affected in Charcot-Marie-Tooth directly by mutation in several genes. Proteasome and protein degradation, the cytoskeleton also is affected through the mutation of these different protein genes here. Axonal transport could be affected, and also an interesting part is that you have this ER and Golgi that is also affected in Charcot-Marie-Tooth through the mutation of these different genes. So I will spare you to go into the detailed function of all these genes, but I find this picture that was published not by me, but by another eminent researcher in medicine genetics. So you have the reference down here. Is interesting for you, and because you can find these genes when you screen your patient in gene panels. You have genes involved in Schwann cells and myelin sheath function, but I won't go into the detail of it. So as you see, many genes, many functions, and now the question is how come they're all related to a form of neuronal degeneration? That's a good question. Now you find a few articles on the repartition of early onset CMT cases. And here you have a very interesting article, published in GNNP by a group in Japan. And basically, they have a cohort of 1,000 patients affected by peripheral neuropathy in general, and especially Charcot-Marie-Tooth. And what they do observe is they have a proportion of demyelinating Charcot-Marie-Tooth here. But I will let Dr. Massey speak about this form. And you have an axonal type here. And for the axonal type, now if you look at the screen, the genetic screen inside this cohort, you will see these different genes here, and the repartition of this gene according to the population. As you can see, there's mainly MFN2 for the axonal neuropathy. The other ones that are quite important and mutated, but they are mainly affected demyelination here. So you look at this table here, and you see MFN2 is the main gene that is affected in axonal neuropathy, and then comes a series of other genes with more or less different proportions, so 10% MPZ, and HSPB1, which is a chaperone, and GJB1. So what is interesting here, and what I would like to point is these two genes here, together with MPZ, you will find them also mutated in demyelinating type. So, and that's where sometimes it becomes complicated, is the overlap of this gene, and not a strict genotype-phenotype correlation. So as you see, if you go down the list, the proportion of genes is becoming very low, and you have a very rare form of Charcot-Marie-Tooth caused by this gene, like NFL, GAS, or SEXT here. So it means that these different forms here are nothing less than very rare, and you're very unlikely to find them in your cohort. And you really need to look at these genes. The problem with Charcot-Marie-Tooth is that sometimes it overlaps with other pathology. And here again, it's a list of genes with autosomal dominance, X-link, or autosomal recessive. So as you see, this list of genes for axonal, here you have only axonal forms. And sometimes you have an overlap of genes causing either an axonal CMT or demyelinating CMT. And same thing here for some genes that are causing, that can cause hereditary motor neuropathy. So there's an overlap, and it's quite difficult to really be strict in this gene is causing this type of disorder. So you have to be aware of this overlap with other pathology. So you have a few genes that are listed here, like TRPV4, MFN2, MTMR2, that are affecting cranial nerves. And there is cranial nerve involvement associated with these CMT genes. This is quite unique, and there's no other genes, I believe, that are associated with this cranial nerve involvement. And so this is for a simple picture. And now sometimes it could be more complicated, where you do not have just a peripheral neuropathy, but you could have also sign of ataxia, like you can observe when you have variants of NFL2 or variant of Saxine. So not that easy to differentiate them, especially because of this overlap. And you really have to be aware of this. So I told you that axonal neuropathy were started in the first decade, second decade, but in fact you can have also late onset neuropathies, axonal neuropathies. So they are triggered over 65 years old, and this was published very recently in this very nice article in Neurology. And what they have done, they took different cases, so 126 cases. So it's a small cohort, but still it's interesting. And they screen for this for the whole exome sequencing. With whole exome sequencing, they screen for genes involved in axonal neuropathies. And this could solve only 23 cases out of this 126. And what they found is a very different profile according to the results. As you can see here, you have this MME protein gene that is highly mutated if you go over 65 years old. And you can see here that the genes are a bit different from the previous slide I shared with you. So there's a different pattern suggesting that these genes are pretty slow to trigger the disease. And this gene is particularly interesting because it encodes a protease, a metalloprotease, neprilysin, and it has been quite a lot of, it has triggered a lot of interest in the literature recently. So a very different profile if you're looking at late onset neuropathy. And here I will share with you a story we had with Dr. Massy on a rare case of Charcot-Marie-Tooth. So we had a mutation in FIG4, and I was telling you that sometimes you have in your cohort only one patient, and now what do you do with this patient? And you try to figure out if the variants that you have are pathogenic or not. And I think that's the challenge of all these very rare form of Charcot-Marie-Tooth when you have one or two patients in your cohort. So for this patient, he was followed in the clinic of Dr. Massy for a long period of time, and we had the report of his electrophysiological data, and he had both myelin. The myelin was affected, and the axon also. And what we found a mutation, classic mutation causing Charcot-Marie-Tooth that was described in the literature, and an intronic variant that was a transversion before the intron 17. So here, what we've done to be sure that we got we had the right candidate, we took the fibroblasts of the patients, and we use the fibroblasts because they could be very informative. And this FIG4 is expressed in the fibroblasts as well as in all the other cells. And as you can see here on this Western blot analysis, the FIG4 expression level in the patient were highly non-regulated. So we had a recessive form here. And we could find also a difference in the repartition here of the lysosome in the fibroblasts of the patient, which was described as a characteristic of these mutations. And altogether, we are sure that these mutations that was described were actually pathogenic. So when you find these rare variants in your cohort, you somewhat need to find a good biomarker and be sure they are pathogenic, and that's what we did for this patient here. So now the question is, as you can see, there's many genes. They are all involved in specific function. But one of the problems is that if you want to treat this patient, so you can tackle one gene by one gene, which means 100 genes plus all the different variants you can find within these genes. But also, what was interesting is that we show that for some genes and proteins that are coded by these genes, they are going toward converging pathway. That was the case with the FIG4 I was describing before. And the FIG4, for example, maintain TRPV4. So this guy here, this channel at the plasma membrane. So sometimes you can have an interaction between two different forms of Charcot-Marie-Tooth or axonal neuropathies because there's a functional interaction between the proteins. That's also what we find in what I call neurofilament disorder. So neurofilaments disorder are caused by mutation in neurofilaments or affect the neurofilaments, which are the intermediate filament of the neuron. So it's it's an important part of the cytoskeleton. And when you do express in motor neuron, for example, this mutant causing Charcot-Marie-Tooth, you have this characteristic bundling of intermediate filaments. Whereas here you can find this very nice network of neurofilaments. Now, if you look at these neurofilaments, they are particularly interesting because you have a lot of converging genes and pathway coming to them. So the filaments themselves can be mutated in Charcot-Marie-Tooth type 2E and 1F, but you have also chaperones like HSP27 or RSACs that are mutated in axonal form of neuropathy that are affecting the assembly of intermediate filament. And similarly, you have protein involved in the degradation like gigaxonin or TRIM2 that are affecting also this intermediate filament. And here, what is interesting is, again, the use of fibroblasts from your patient, because they carry this, they bear this intermediate filament network called vimentin. And you use this vimentin network as a biomarker of the pathology. And if you look here in the fibroblasts derived from the RSAX patient, you have the formation of a big ball or bundle of vimentin, whereas normally the vimentin network distributes in the cell. And you can observe a similar feature for in fibroblasts derived from patient affected by a mutation in gigaxonin here. And you use these markers, actually this phenotype, as biomarker of the pathology here. And which means that these neurofilaments are a key point in the pathology. So that's what we tried to figure out in the lab. And we found a role of a kinase here, and it's an adapter. And in fact, this kinase is entrapped into these bundles of intermediate filaments here in RSAX and gigaxonin. And if we activate this kinase, we can resolve these bundles, and which means that this is possibly a common strategy for these different, for at least these two forms of axonal neuropathy. So as you see, you can either treat one by one all the different genes, or you can find some commonalities between the different forms. And if you find commonalities between the different forms, you can actually work and try to figure out a therapy that will be efficient for these different forms. So another aspect of axonal neuropathy that was very interesting and excited a lot of people in the field came from several publications. And this set of data was suggesting that axonal neuropathy could be reversible. And if you look at lessons from mice, for example, this was the mice described in Jean-Pierre Julien's lab. So you have a mutant here, an FL mutant, causing Charcot-Marie-Tooth. This is the mice with the feet here. As you can see, the mice drop the feet. And this mutant is under the promoter of tetracycline, so meaning that you can shut down the expression of this mutant. So when you shut down the expression of the mutant, you can see that the mice can recover to some extent from the injury. A similar type of work has been done in Ludo van den Bosch lab, a laboratory, and this time he used a mice model expressing this HSP27 mutant, and he treated with HDAC6 inhibitor. And what he found is that after the mice developed this characteristic phenotype of Charcot-Marie-Tooth here in the feet, you treat with HDAC inhibitor, and the mice restore his foot as if normally. So it was very interesting because, like I say, it suggests that axonal neuropathy are reversible. And I think this is all depending on the extent of the damage. And it's true here in cells, what we have done in the lab, we work on CMT2E in neurons that are expressing this mutant. And this mutant is actually forming little aggregates in the neurons. We treated with celastrol after the formation of these aggregates. And the celastrol, which is nothing less than HSP inducer, was able to reverse the formation of aggregates, and this mutant finally aggregates into, assemble into a normal intermediate filament network in the neuron. So again, here it shows that some form of CMT could be reversed, but again here it will depend of the extent of the axonal damage. So in conclusion, as you can see, regarding axonal neuropathies, there's quite a lot of genes. The path is tricky. There's a lot of genes. You will find probably one or two in your cohort, and this one or two very rare variants you will need to find if they are pathogenic or not. So that's the other difficulty. And the axonal neuropathy are also difficult because of the complexity of the phenotype. They often have ataxic features, central features are also described. You may find genes classically affected in axonal neuropathy, in cohorts of ataxic patients or other. Like I say, you often identified one case in your cohort, especially if it's one of these rare genes, and you will have to find out if it's a variant or not. So that's the main difficulty I find in Charcot-Marie-Tooth. After that, I think we need to find what are the functional interaction between the different genes. This will help a lot because it will lead us to the common functions that are affected. And if we know these common functions, then we can find treatments that will benefit several patients. Another aspect that was very interesting, and we need to see if it translates to human, is that this reversibility, which is linked to the importance to find treatment and treat early on. So I would like to thank several people, Dr. Durham, Sandra Minotti, Nancy, Fruz, Alexandre, Zachary, Robin, in my lab, Dr. Massey, of course, who is my a very important collaborator for me and a good friend. Several foundations like Muscular Dystrophy Canada, the Ataxia Foundation, and other people in France, Germany, but also in Montreal. So thanks a lot for your attention. I hope I didn't go too fast. And yeah, here we go. Okay.
Hi, it's Alec here, Alec McKenzie. Maybe in the interest of time, given it's past 5:30, we can just go to Remy, and then we can see if there's questions at the end. Is that would that be okay, Remy?
Sure, of course. So thank you for the invitation, Benoit. I was asked to present on demyelinating neuropathies, and I'm happy to do that. My talk is very simple, it's very short, and it's a more clinical talk. Share screen. Share. Here we go. So yeah, so it's mainly a clinical talk. I'll go over the, a quick introduction, the differential diagnosis of demyelinating neuropathy. That's a mistake, not inherited, demyelinating neuropathy. And then I'll review the genetic causes of demyelinating neuropathy. And then I'll talk about clinical presentation and management of demyelinating inherited neuropathies, which is pretty similar to the presentation and management of axonal inherited neuropathies. These are my disclosures. There's nothing directly relevant to the talk, but I am the PI of a study for CMT1A that I will be discussing later in the talk. Here we go. Okay, great. So I think we all know that nerve fibers transmit the axons. The nerves are actually the axons of neuronal cells. They can be surrounded by layers of Schwann cells that form myelin cells. So it's a fat layer that's isolated from the outside. Or they can be naked axons, still surrounded by some Schwann cells, but not with myelin. And usually motor function and balance and proprioception are transmitted through those large nerve fibers that are myelinated, whereas pain is transmitted through the small unmyelinated sensory fibers. The role of myelin is to allow decreased leakage of current in those larger nerve fiber, but mainly to isolate current so that you have, instead of having progressive transmission of your electrical signal, you have saltatory transmission of your electrical signal. So it jumps from one node of Ranvier to another node of Ranvier, which makes the conduction even more faster, independent of the size of the fiber. So that increases your nerve conduction velocity without having to increase the diameter even more. So demyelinating neuropathies are neuropathies where the process or the problem is mainly in the myelin sheath surrounding the nerve. And I have to say that almost all demyelinating neuropathies will have some form of axonal damage. And often early on, you don't have a lot of axonal damage, but as the years pass, the patients accumulate this axonal damage, and often the degree of disability is proportional to the degree of that secondary axonal damage in the cases of inherited demyelinating neuropathies and also acquired demyelinating neuropathies. So when we talk about demyelination, we talked about two main processes. We talk about segmental demyelination, meaning affecting certain areas along the nerve, but not the whole myelin throughout the whole nerve, versus diffuse hypomyelination or dysmyelination. And often when we talk about segmental demyelination, it suggests an acquired disorder, whereas when we talk about diffuse hypomyelination, it's more commonly inherited. But like everything in life, there are exceptions. There's certainly some some inherited disorder which will leave you with segmental demyelination, such as HNPP or hereditary neuropathy with liability to pressure pulse. All right, so this is the differential diagnosis of demyelinating neuropathies. And as you can see, there's two very big categories. You know, you have your immune-mediated neuropathies or your inherited neuropathies. And, you know, to make things even simpler, whenever I see a demyelinating change on nerve conductions, whenever I see a demyelinating neuropathy, my thinking is this CIDP or is this Charcot-Marie-Tooth? Obviously, there's other things on that differential diagnosis, and usually once I have excluded either Charcot-Marie-Tooth through genetic testing or CIDP through you know, clinical presentation or lack of response to treatment, then I start going over the other possibilities unless there's any obvious history for that. So don't forget some infectious causes for demyelinating neuropathies. I've never seen a case of diphtheria myself, and I've seen leprosy, but not presenting as a demyelinating neuropathy. But I've certainly seen both HIV and syphilis presenting as AIDP. There's some drugs that causes demyelinating neuropathies, and we often think of amiodarone and TNF-alpha antagonist. These are the two big categories. I think the other drugs are either controversial, like allopurinol or tacrolimus, or just not used anymore, like perhexaline. And then there's some toxins that definitely can cause demyelinating neuropathies, but I have to say I've never seen or at least recognized any of that. So again, think CIDP versus Charcot-Marie-Tooth. The big, so I just want to come back to one comment Benoit made, is that, you know, whenever you see a demyelinating neuropathy and then you do the panel, and sometimes, you know, we don't find a specific cause in the panel, you have to make sure you look for other small, subtle neurological dysfunction. So you have to look for ataxia or spasticity, because sometimes those abnormal genes overlap, like Dr. Gentil mentioned, and instead of finding the answer by doing a CMT panel, you may want to consider other panels, such as an hereditary spastic paraparesis panel, which can also be associated with neuropathy, or an ataxia panel. And in particular, for demyelination, there's some leukodystrophies that can actually present as a demyelinating neuropathy, you know, almost always in children, before presenting some of their central dysfunction. I mean, some of those leukodystrophies can have adult onset. I haven't found a case report of an adult onset demyelinating neuropathy that eventually developed a central dysfunction, but there's certainly cases of demyelinating neuropathies in children where the leukodystrophy parts becomes obvious much later, and where the initial MRI can be normal. So think of doing an MRI of the head on some of your demyelinating neuropathies if you're unsure of the diagnosis and if your panel is negative. CMTX, secondary to JGB1 mutation or connexin 32 abnormalities, can sometimes be associated with some white matter lesions. So it's also worth considering an MRI in these circumstances. I'll discuss this quickly at the end. I often quote this older article. It's an AANEM monograph, and one of the main authors is Dr. Klein, published in Muscle and Nerve in 2013. Basically, it's a review of inherited neuropathy, and what I really liked is the introduction, where they go over clues to recognize inherited neuropathies. So obviously family history is a big clue. You know, if somebody tells you that my father and all my uncles or aunts had neuropathy and have the same thing I have, it's quite helpful. Unfortunately, this is becoming less and less helpful now for several reasons, but I think the main one is because we have smaller families. So for autosomal recessive disorders, it's not that obvious. So family history is key, and don't just ask about, you know, do your parents have neuropathy? You should try to dig more. You should tell them, have you called your sister lately, or you haven't spoken with her in 20 years? You can give them assignments. Why don't you go home tonight and call all your siblings and ask them if they have numbness in their feet, because it's not something necessarily you discuss on a regular basis over dinner. And if in doubt, you can certainly invite those family members who have vague symptoms and examine them or do an EMG on them. So other than family history, often the patients have a slow progression of progressive symmetric deficit. They often start in childhood, and they're often unrecognized for a long time. So you often hear the story of somebody who's been flapping their feet, slapping their feet when they're walking, and who hasn't noticed it, but their spouse will tell you that, you know, I've been hearing them slap their feet for at least 10 years. And it's often unrecognized because some of these inherited neuropathies, or at least the Charcot-Marie-Tooth, are motor predominant. So they present with progressive distal weakness and foot drop, but they don't have a lot of positive sensory symptoms. They often have mild sensory loss. So the patients don't notice the progressive ankle weakness until later on. So slowly progressive symmetric course, childhood onset. Often they have poor sport performance and recurrent ankle sprains. I tell my residents that if somebody was born in Quebec or in Canada and can't skate, they have Charcot-Marie-Tooth automatically. Obviously, I'm exaggerating a little bit, but it's a big clue often for the diagnosis of inherited neuropathy. Obviously, there's some exceptions to what I'm saying. I don't think we have to go in details, but HNPP is an exception of symmetric course. SEPT9 mutation will give you recurrent brachial plexitis, but this is not inherited. And I had a very interesting case of myelin protein 0 mutation, which was responsible for CMT1B that presented acutely at an older age. And that has also been described with MPZ, but is certainly a little bit atypical for an inherited neuropathy. And then the biggest clue often is refractory response to treatment. Like I said, often when I see a demyelinating neuropathy, I tell myself, is this CIDP or CMT? And if I think it's CIDP and I treat them IVIG steroids and they're not responding at all, you have to wonder, am I missing an inherited neuropathy? And actually, this is what happened in my myelin protein 0 patient who presented very acutely after a gallbladder surgery. I was convinced this was immune mediated given the acute onset. He was playing basketball 3 weeks before. And then he didn't respond to treatment. I did a genetic panel. And then after the panel, I found the MPZ mutation. And then we discovered that he actually did have a family history that he didn't know about. And it's only after he called his brother that he discovered that his brother had an inherited neuropathy too. This is a table of the common genes causing inherited neuropathies. So CMT1 is autosomal dominant sensory motor demyelinating neuropathy. CMT2 is axonal, so I won't cover those. CMTX is the one caused by X-linked mutation. So CMT1A, 1B, 1C, so are clinically very identical. As I said, they present in a very similar way, and you can't really distinguish them simply clinically. As I said, CMT1B, secondary to myelin protein 0 mutation, can sometimes present acutely, and CMT1B, myelin protein 0 mutation, can sometimes give you a later onset form with less obvious demyelinating changes and has been classified as an axonal CMT as well. But other than that, they have a very similar presentation of uniform slowing of conduction velocities. CMT1A is due to PMP22 gene duplication. So there's too much PMP22 gene, and therefore there's too much PMP22 mRNA. And similarly, myelin protein 0 mRNA is also produced in excess. So often that's an interesting pathway as well that's worth considering targeting when you're looking for treatment, is that there's a role of the amount of gene expression, and modulating that gene expression can maybe lead to treatments eventually, even though that hasn't been successful so far. CMT1E is basically a point mutation in the PMP22 gene rather than a duplication. I have one patient with that, and interestingly, they don't have deafness, but they have an overlap between typical CMT1A phenotype and more of an HNPP phenotype. HNPP is an unusual inherited neuropathy that presents with focal, recurrent episodes of focal neuropathies and pressure palsies, basically, but they also have a length-dependent sensory predominant polyneuropathy, and that's due to PMP22 large deletion. So if you have a large deletion in PMP22, it gives you HNPP. If you have a duplication, it gives you CMT1A. And if you have a point mutation, it gives you CMT1B. Those are the same genes that will give you CMT3. So CMT3 or HSMN3 is also called Dejerine-Sotas syndrome. And it's basically a more severe form of a demyelinating neuropathy, which by definition presents within the first 2 years of life, and which also by definition has delayed motor milestones. It's basically the same genes with the exception of periaxin. And then finally, we covered that. Oh, so sorry, before moving on. So CMTX will give you intermediate slowing of conduction velocity. And since this is an X-linked gene, it will give you a much more severe phenotype in male compared to female who have another X chromosome and who can compensate for the mutation in their other X chromosome. Whereas the male will only have one X chromosome, and that mutation will give you a more severe phenotype. So if you have a young man who tells you, yes, I think my mom has CMT, but it's very mild, much less severe than me, but me and my uncle have terrible CMT, that's a clue that it could be CMTX. The other clue is that that uncle has no sons who have CMT, because you can't have male-to-male transmission of CMTX, since if you have a male, the father gives always the Y chromosome, right? And finally, CMT4. So CMT4 is basically autosomal recessive CMT. Most of them are demyelinating. Some of them are axonal, but most of them are really demyelinating. You know, I have to say that they don't talk a lot about that in charts that, you know, even Dr. Gentil presented, but I've been impressed. I think I have more cases of CMT4 than cases of CMT2. I don't have that many cases of classic CMT2, even though mitofuscin is supposed to be a very common mutation. I think I only have one patient with actually a VUS in mitofuscin, but I have quite a few patients with unusual forms of CMT4. SH3TC2 mutation gives you a severe demyelinating neuropathy in childhood with scoliosis. And I have a few patients with that. There's a cluster described by Dr. Bray, who comes from Passepébiac in Gaspésie. I have a patient with SBF2 mutation, and Dr. Gentil discussed the FIG4 patients we saw together. So I actually have quite a few autosomal recessive CMTs, and maybe that's just the bias of our population here in Montreal. As I said, always think of possible leukodystrophy. If you're convinced this is inherited, but your CMT panel is negative, consider doing a brain MRI. Usually they have obvious CNS dysfunction as well. So metachromatic leukodystrophy is associated with a demyelinating neuropathy, and globoid cell leukodystrophy or Krabbe's disease is also associated with that. And finally, just one quick word on this very interesting entity where several families have been described having a mutation in the PRNP protein, which is gene, which encodes the prion protein. So this is a prion disease, genetic prion disease that presents as an autonomic neuropathy with severe GI dysfunction and some sensory dysfunction as well. So this is an unusual phenotype for sure. And, you know, I was quite doubtful when I read the first publication in 2013, but there's been several other families described since then. They have clear neuropathic changes. They have abnormalities in their prion protein, but they also have amyloid deposits. And I don't have a nice picture of that, but those prion abnormalities lead to amyloid deposits, and they present as demyelinating changes on nerve conductions. All right, how are we doing for time? Maybe 4 minutes. I'll just summarize a typical clinical presentation. So I think I went over the main genes that cause demyelinating neuropathies. Now I'll just summarize the typical clinical presentation of inherited demyelinating neuropathies. Like I said, it's the same presentation as axonal neuropathies most of the time. And obviously we can't generalize to all possible genes, but grosso modo, they will present in their teens, sometimes in their before that in childhood, but usually in their teens with progressive distal deficit. And most of the time, they present with motor symptoms first, motor manifestation. So they have progressive muscle atrophy leading to abnormal appearance of their feet and to ankle dorsiflexion weakness, recurrent ankle sprains, poor sport performance, and eventually they develop a complete foot drop, and it becomes apparent when they walk. So there's this progressive there's this progression that starts distally to proximally of motor symptoms first, and then sensory symptoms, which are often negative sensory symptoms. So loss of sensation, not as much tingling, maybe a little bit of numbness, but maybe mainly loss of sensation, that dead wood feeling, and not a lot of autonomic dysfunction for their Charcot-Marie-Tooth patients. Starts in their feet, then their legs, then their hands, and rarely up to the distal thigh. And often they're unaware of these deficits. It's a constant slow progression, but there's some stages in life where they progress more quickly. Pregnancy, often due to increased weight, increased stress, basically on the nerve, which has to, just essentially increase stress on that cell. they have a superimposed focal neuropathy that can explain some more rapid progression, like a superimposed carpal tunnel, and the patient tells you I'm much worse, but it's actually just that carpal tunnel, and they do get better when you operate on them. And then there's a description of a superimposed inflammatory neuropathy on CMT1A. I have to say I've never seen that or recognized that. I think it's very important when you see patients to remind them that most of them, and especially the CMT1A patients, have a normal life expectancy, and that they can have very good quality of life. They can walk almost all their lives, and eventually they'll need ankle foot orthosis, but it's quite rare that they need a wheelchair, and it's often because there's superimposed other comorbidities. All right, I think we talked about that. And then on examination, they should have some loss of ankle reflexes. And one of the only clue I would say between an inherited and an axonal neuropathy clinically without having an EMG is to look at the reflexes, because often axonal neuropathies will have only distal areflexia, whereas inherited neuropathies will give you generalized areflexia. This is just some pictures. You can see the increased callosities because of the abnormal walking. Clearly, this patient is walking a little bit more on his lateral edge of the foot. They often have this bump here, the high arch here. So this is a typical pes cavus appearance. They have the hammer toes here. So those retracted toes that we call hammer toes. They have a claw hand due to significant atrophy of their lumbricals and other intrinsic hand muscles. And then they have this stork leg appearance or inverted champagne bottle appearance, where you have significant atrophy distally at the level of the distal leg, but relative preservation higher up of the calf, and certainly preservation of the thighs. So management is a little difficult and frustrating. I always, I see a lot of CMT patients, and I keep telling myself I wish I could do more. Obviously, genetic counseling is important. Finding the genetic cause so that you can tell them the risk. And we have a good genetic counselor, but I certainly don't refer all my patients to her. I would say that I refer only patients who need who are considering IVF, and I think most of them, most of the patients have mild deficits and wouldn't consider that, but some of them do. AFOs remains one of the mainstay of treatments, and I'm not an expert of AFOs, but I think what's very important if you see a lot of CMT patients is becoming friend with a good physiatrist, and a physiatrist with experience with orthosis, and knowing where to refer your patients to good orthosis specialists. We do refer to OT and PT here in our hospital or to rehab centers. I think that not everybody necessarily needs that referral, but depending on symptoms, I find OT very helpful for people who have hand weakness, and they can add some small gadgets that make life easier, everyday life easier. Often patients have pain. That's an often forgotten part of inherited neuropathies. So offer treatment for that. I almost never send patients for surgery because I see adults. It's quite different for children where they do often heel cord lengthening, but in adults, the role of surgery is really limited to people who have recurrent ulcers, basically. And then I think changing the walking mechanics may be indicated. I gave them a list or a website of neurotoxic medication to avoid. I have to say I do it mainly to feel better about myself. I'm not sure how helpful it is because most of these medications are, chemotherapies and very rare drugs that, are rarely prescribed. Actually, the only one I often stress on is colchicine. There's a lot of patients on colchicine every day for unclear reasons. I think it should be reserved for to be taken only when you have a gout attack and not every day. So I often stop colchicine on all my patients. And then finally, I think it's good to have some form of clinical trials. And I haven't been able to have a clinical trial here since I started, but we are starting one soon with a compound called PXT 3003 for CMT1A. So if you have patients you want to refer to us, we'd be happy to see them for that. I think patients are happy that we're doing research on them, even if it doesn't lead to treatment. Dr. Gentil and I also collaborate on other patients on whom we harvested some fibroblasts and then did some basic science. Well, I didn't do anything, but he did the basic science experiments. I think that even if it doesn't lead to a treatment, they're very happy that we're interested in them and that we're doing research on their disease. That's all I had to say. I talked a lot. I'm happy to take questions now or later.
Great. Oh, Remy, hi, it's Alec. I'm the next speaker, so I can ask you a question. What is an AFO?
I'm so sorry. Ankle foot orthosis.
Oh, okay.
It's an orthosis you put in your shoe and that goes up to your calf and it helps lift your ankle up. So it prevents fall and stabilizes your ankle.
Okay. And then the only other thing I just say quick, I know people want to get out of here. The sad thing about Zoom calls, you can track your numbers and you can see when it's dinner time. But the only other thing I would say, my laboratory studied how drugs and genes that go up and down, and our most profound observation was PMP22 is very responsive to thyroid. Basically with thyroid and thyroid mimetics, it shoots up. So all I just say as a pediatrician that knows nothing about it, if you have an HMPP patient, check the TSH, because sometimes hypothyroidism can sort of unmask it.
That's a fantastic advice, I think. So I'll be doing that.
Okay, all right. And conversely, I think you want to avoid thyrotoxicosis in the CMT, in the triplicate PMP22. That can make things worse. But anyway, yeah, okay. That was just my one thing. I don't know. Does anybody else have a quick question? I'm going to try to blow through mine in 15 minutes. But does anybody have a question for Rami?
Is remyelination efficient in peripheral demyelination disorders? What age groups are included in PXT 3003? So the age groups are 16 years and older. Yeah, it's for exactly, that's CAM2. Yeah, 16 and older. I don't know if there's an upper age limit. I think it's 70, but I think it's 70, 16 to 70 for that trial. Remyelination and peripheral demyelination disorders. I don't know. Who wants to answer? Benoit, do you want to answer that?
I do not know. I know in mice it's possible. You have this mice treated with cuprizone. You treat them with cuprizone, and when you remove the drug from the diet, the mice remyelinate quite fast in weeks. So, but I do not know in patients how fast they remyelinate. But I think it's possible. Yeah.
Great. Okay, Remy, thanks very much. Those are great two talks, but now for something completely different here. Okay. Am I sharing? Oh, just a minute. Share screens from beginning. Oh, just a second. Okay. Hamir, am I sharing okay?
Yeah, looks great. Go ahead.
Sometimes I find it hard to share. Okay. Hi, I'm Alec McKenzie. I'm a pediatrician masquerading as a neurologist or a pediatric neuromuscular person. I'm just a pediatrician who's been asked to talk quickly about riboflavin transport deficiency. And right up front, I have to say that these are slides from Keith Massey, who I hope is still on the line, who single-handedly has really, he has a lovely daughter, Julia, with riboflavin transport deficiency, and single-handedly with his international Edmonton-based outfit has transformed the actual field as far as research goes. I know a lot of rare diseases, and it's been one of the most really impressive, I have to say. Quickly, these are disclosures, consultancy for Biogen and Novartis, which I feed back into research. Although, given the costs of the drugs, I sometimes lay awake at night wondering about it. And also, I got money to do a newborn screen with Pranesh in Ontario. So quickly, riboflavin transport deficiency, RTD, it's animations, I apologize. Early onset, life-shortening neurodegenerative disorder, recessive inheritance. It was previously known as Brown-Violato, Bandler, BVAL, and Fazio-Landi syndromes. It's a sensory and motor neuropathy, as well as a cranial neuropathy. There's two main types, RTD2, which is the type riboflavin transporter deficiency of the type 2, encoded by a solute carrier 52A2. And then type 3, encoded by a solute carrier number 3. It's 1 in 500, so it's the rarest, one of the rarest conditions we're going to hear about this evening. If you do the Hardy-Weinberger math, it works out to 1 in a million births. Keith, who has tracks this closely, has got about 150 cases of RTD type 2 and a bit lower number of the RTD type 3. Type 2, a bit more severe, onset at 3 years, 7.6 years for type 3. Mean age of death is 12.6 years, usually respiratory insufficiency. Here are the transporters. I don't know if you can see the mouse, but basically, we don't get a lot in the way of riboflavin. We don't make it, we eat it, right? It's dietary. And so basically, transporter 3, bringing it in from the intestine into the blood, some activity of transporters 1 and 2. And then in the blood-brain barrier, we see transporter 2, possibly transporter 3, a little bit of a mystery there, and then maybe some other means of transport across the blood-brain barrier into the CNS. We're going to talk a bit about this OAT3 that takes it out back to the blood in the final slides of my talk. Here is the tissue expression. So you see intuitively expression there in the brain for 2, not so much in 3. In point of fact, more in the small intestine, even the testis. Nonetheless, they are neuronal disorders. So this is one of the mysteries, minor mysteries about the riboflavin transport disorders. Just about the actual riboflavin itself, here we see flavin on this side made into riboflavin over here, and then there's a mononucleotide, FMN, and a dinucleotide, FAD. And there are about 90 genes that are flavin-dependent enzymes within the proteome. These are important proteins which require these flavins as coenzymes for cell regulation and energy metabolism. And where it hurts the most is in the central nervous system, although there's expression throughout the body. I'm just going to move this over to one side so I can actually see it. And so basically, when you look at the clinical features, auditory neuropathy is present in both type 1 and type 3. We've got pontobulbar involvement in both, respiratory compromise in both, muscle weakness, optical atrophy in 2 more than 3, and more gait ataxia and sensory involvement in the 2 versus the 3. They have other problems such as GI distress, dysmotility, and scoliosis. When you look at the presenting features, there's a bit of disconnects here insofar as hearing is a thing. It presents more after the age of 6, with about a third or so or a quarter doing it before the age of 5. Pontobulbar involvement primarily in type 3, and conversely, sensory involvement and ataxia more in type 2. Respiratory compromise in both, more severe in type 3, and there's a megaloblastic anemia that Keith has found that presents in type 2. Interestingly, there's SIB splitting, and therefore there might be genetic modifiers. So you have identical genotypes and quite profound phenotypic differences. Laboratory findings include increased short, medium chain acylcarnitine. Riboflavin may be low or normal. In the CSF, it's usually low. Signs of mild mitochondrial dysfunction and low hemoglobin and iron and ferritin levels, macrocytic or normocytic anemia. They've got elevated ethylmalonic acid in about half. The neurodiagnostic tests show EMG and nerve conduction studies show the slowing that one sees with partial denervation. The MRI is largely unchanged. There is, in type 3, you have cerebellar and brainstem abnormalities, and there's absent auditory brainstem responses. The hearing loss is pronounced. It's consistent with auditory neuropathy. Over 40 patients have now cochlear implants with variable results. The earlier you get there, the better the results. But as Keith says, huge impact on these people's lives. Here's just an exemplar of the actual gene itself. parenthetically, it looks large. It's not so big. It's roughly 500 amino acids or less. You can put it in AAV from a therapeutic point of view. So as AAV comes along, and we get endothelial targeted AAV, it would be an option. The mutations are the blue dots, so you can see it's scattered throughout. Mutations roughly, and here account, I'll show it to you better in the next slide, for 50%. So here, scattered along the structure, you see mutations everywhere. The ones up here count for about 50%. Two of the mutations up here count for about, are present in about 50% of the individuals. Complete loss of function is not seen. It's usually hypomorphs, relative loss of function, and this is borne out in the animal studies as well. And it stops the riboflavin transporter from going to the surface, and it stops its function. The fact that it gets tangled up and stops its mobility to the surface indicates that chaperone therapies might be useful, whereby you disentangle it from the Golgi apparatus and get it out. But overall, the upshot is reduced riboflavin transport, and the main choke point is transport across the blood-brain barrier into the CNS, resulting in reduced CNS riboflavin levels. You get a mitochondrial dysfunction with all these various attributes. I won't go into each of them, as well as cytoskeletal abnormalities and neuroid outgrowth dysfunction. You can treat it with riboflavin. You do treat it with riboflavin. Keith has found that a challenge is getting the diagnosis early enough so you start treating early enough. Even when you get treating early enough, it doesn't stop progress. And the reason we think might be its short half-life. It peaks at 1 to 2 hours, and then it plunges down. By 6 hours, it's back down to baseline. And so there's been one small study where they did it every 6 hours dosing, and it seemed to make and have an impact. So I think the simple answer might be maintaining the bioavailability in the CNS might be the challenge, and why we're not getting the profound long-term effects. Keith might argue that there's other functions that we're not covering off of the riboflavin. I wonder if it's bioavailability. There are complementary treatments that have come along: coenzyme Q, carnitine, B complex. Fussing with the flavin mononucleotide itself by esterifying a riboflavin so it's got better blood-brain penetrance, although there's problems with that. None of these have really knocked it out of the park that we're aware of, and none have been subject to real sort of scrutiny by prospective clinical trials. As I say, a short-term, 75% of clinical improvement. The earlier you get it, the better it is. Long-term, many report new or worsening symptoms. More research is needed for novel therapeutic strategies. Keith and others has spent a fair bit of money getting animal models going. There are ones coming out of JAX. The punchline is there that nulls are not viable. So trying to get sort of hypomorph mutation mix and max to get a good mouse model. And I think it sounds like Keith is getting close. We've got a bottle of wine riding on which one we think is going to win. Zebrafish I'll tell you about in a second. And as well, apparently in Australia, they've got C. elegans. Just want to finish up here, just talking about what I think is a clinically low-hanging fruit. And I would encourage anybody with patients to think about this approach. One looks at the bottom here, one sees that basically you're moving the riboflavin in with this transporter. You're moving it out with this so-called organic anion transporter 3 that moves it out of the brain. And it turns out probenecid, the anti-gout drug, not only stops penicillin transport and uric acid transport, but it is also a very effective inhibitor of riboflavin transport. Therefore, the efflux of riboflavin would be materially inhibited if you treated the patients with probenecid, a safe, bioavailable drug. And being a sort of a dysfunctional pediatrician that can't get the clinical trial going, it makes me a little crazy that we haven't really moved on this. What we're doing here in Ottawa is we're doing, and this is in Hans Lochmuir's lab, we're knocking it out of zebrafish. And right now, Emily and Catherine, who may or may not still be in the audience, have shown that it's the two transporters are expressed in zebrafish early on. They can knock it down early on. And it seems there might be a phenotype early on. It doesn't hit viability, they're fine. But it looks like, although it's preliminary data, it looks like you might get a variation of the little embryo within the chorion as you knock it down. So hopefully there may be a phenotype there. This is just a picture, a video, which I don't have time for really. It's just showing the chorionic moving there. You can see it trembling there. So that's exciting. And so basically Emily and Catherine in the Hans's lab, your slides are so busy, it's the only place I can get your names in, guys, are going to establish CRISPR lines. They're going to look for phenotypes all fancy ways, and they're going to give them probenecid and see if they get better. So I think that's an exciting option. And just want to finish off, thank you for all. Here's the hero of the tale, Keith. And one of these is Julia. Perhaps, Keith, you can tell us which one. But thank you, Keith, for getting your foundation going, so I didn't need to get slides ready for this talk. I really appreciate it. So that's it, sort of race through there. A bit like drinking from a fire hose, I apologize. But are there any questions for Keith, Emily, Catherine, or me? And there may not be anybody left in the audience at this stage. Keith, can I just have you just say a sentence or two? Or unless maybe he's left the building.
No, Keith is on the line. I just went ahead and unmuted him. Hold on one second.
He has no mic.
There's no mic. Oh, he got no mic. Okay. All right. Good. All right. I don't know if there's anything in the chat at all.
Yeah, Jim Dowling is asking any thoughts on how we can get to diagnosis faster.
Well, it's really too bad that Keith doesn't, because he's been working on getting it into the panels, and Keith has a PhD in neuroscience, so he's ideally suited for this job, and so he's been talking to people about getting in the gene panels, and maybe Keith could go off video and give a thumbs up or whatever to let us know how that's going, but he's moving in that direction, Jim, for sure. So if there's anybody with patients that are interested in looking at a probenecid trial, just you can give Keith, myself, and probably Hans. I can drag Hans Lockmuller into it as well, and we can talk. Great. And I don't know if this question for Benoit or Rami at this stage. Oh, you do. Jim has two or three. Okay.
Okay, so there's.
No. Hi, Rashmi. No, it's truly recessive. There are no carriers, have no symptoms.
Any thought on how we get to diagnose faster?
So as I said, Benoit, Keith is talking. Keith Massey is talking to the companies or academic labs about adding it to the neuropathy panels.
Yeah.
Yeah.
So I have a question for you. Do you think vitamin, because riboflavin is a vitamin, so vitamin B2, if I do remember correctly.
Yes, that's exactly.
Do you think that vitamin deficiency like this are common also in the population, or should we complement?
No, I speaking with absolutely no expertise or real experience, I don't think there are occult vitamin deficiencies causing neurologic certainly things. So I don't, in the Western society for sure, I don't believe that's something. I think riboflavin from a recessive disorder is, that's a clear condition, but I don't think vitamin deficiency is a common undiagnosed thing. I'm sure there's others on the line who know more than I.
Okay.
Okay. Well, thank you everybody for.
There's a few comments. Question. There's a question from Dr. Lockmuller to Dr. Gentil. How specific are the vimentin abnormalities in fibroblasts for certain types of axonal neuropathy?
So the vimentin abnormalities in fibroblasts are useful if you have a gene that is affecting the intermediate filament in general, like gigaxonin or saxin. But for example, if you have mutation in TRIM2, TRIM2 is expressed in neurons only. So you will not see, and TRIM2 has been shown to be involved in the degradation of neurofilaments. So you won't see anything in fibroblast. Also, so you really need to have a gene that is not specifically expressed in neurons if you want to see any abnormalities in fibroblasts, which was the case for FIG4, for example. The FIG4 was deficient also in the fibroblast, and that's how we could see the phenotype. So I think that's the limitation to use fibroblasts. That if you have indeed a gene that is specific for neurons or Schwann cells, then you probably won't be able to detect any abnormalities or phenotype in fibroblasts. Yeah. Does that make sense?
Then we have a comment from Dr. Dowling, who
Yes, yeah. Jim says that he's got some patients there, and then we have to do the diagnosis early for the riboflavin early in the WS to stop the diagnostic odyssey, I think, Benoit. But my very, very good friend, also Cheryl Greenberg, is asking a very clever question about whether or not the carnitine deficiency is so pronounced that we might look at newborn screening. I don't think so, but I'm certainly going to ask Pranesh and Keith for their thoughts about that, Cheryl. A good out-of-the-box question for sure.
Do we have any other question?
Yeah, we have Dan Naus who's saying, I have likely CMT2 and screening in hopes that it is SORD. So we didn't talk about SORD, but this is a newly described gene in the last year or year and a half maybe that is potentially a treatable neuropathy. So you know, I think it's part of panels now. So
Okay.
All right.
All right. I think we are all set.
Very good. Thank you all.
Thank you.
Thanks a lot, everybody. Thanks a lot, Dr. Mackenzie, for this navigation in the riboflavin
Our pleasure.
ocean. So that was very good.
Okay. All right. Thanks, guys. Bye.
Thanks. Bye-bye.
I just wanted to thank all the presenters and also Hamir at MDC. And also was hoping that you could all complete the webinar survey. We're going to send that out shortly. And if anybody would like a certificate of attendance, just indicate so on the survey. So thank you very much. And I hope you all have a great night.
Thanks, everyone.
Thanks a lot.